Well, welcome to our Lunch and Learn series. This is Rani Singh. I'm the director of the Genetics Metabolic Nutrition Program and also the PI for the HRSA grant funded for the Southeast region. I welcome all the people who are physically here, but also I know several of you are attending this session off-site. So I'm totally excited to remind everybody our grant through Health Resources and Service Administration with newborn screening and genetic disorders. We have been funded since 2005. So this is our fourth cycle, and this is the beginning of the fourth cycle with next 3 years. And the focus moving forward for the cycle, what we have written is telemedicine. We have, and the long-term follow-up, which has been a big strength of our region. So we'll be following those two aspects for the Southeast region. Today, we will start with the discussions on telemedicine. Our first speaker, we are going to talk about the Project ECHO, and you'll hear from Acha the introduction about our speaker. But this series will also be taped and be available on the SERN, our Southeast Regional Network website. Formerly, the name was Southeast Regional Collaborative, or we called it SERC. And moving forward, we have been basically guided nationally to call it SERN. So this will be available on the SERN website. So please encourage your colleagues to go back and listen to it. We have proposed 3 models in the upcoming cycle for initiating telemedicine in our region. One, physician-based model with the team. The second, a nutrition-based model, which we'll be leading for a clinic for the telehealth component, which we will be leading from Emory University. And then the third, genetic counseling-based model / nurse practitioner model, which we are still going to be looking for grants and opportunities for people who want to start. We also are targeting the underserved populations, which is a part of the criteria for the grant. And of course, we all know genetic services are so short, and that's the whole idea about starting this project. And one of our goals and focus also is the physician-based clinics, which will be starting in Georgia, would be to target the Hispanic population by physicians who will lead that. So we'll be forming a work group with monthly work group calls, and I will send out an invitation related to that. We are very excited about this opportunity to collaborate, learn, and teach from each other. We will be collaborating with our state efforts and state programs, so I welcome all our state partners who are participating today. We'd be looking for ideas how to make all this work moving forward. It's an exciting emerging field. And at this time, I will pause and let Acha introduce our speaker.
Good afternoon, everyone, and thank you all for being here for the Lunch and Learn. My name is Acha Osara. I'm the project manager of the HRSA grant that Dr. Singh just talked about with the Southeast Regional Genetics Network. As part of the grant initiative, Emory University sponsors a few Lunch and Learn events throughout the year with the goal of highlighting key experts and their research within human genetics. Before I introduce our speaker, just some housekeeping items. We have lunch in the corner over there. There's veggie and chicken. And if you need a parking pass as well, I have those for everyone who's here. Our speaker today is Dr. Matt Hawkins. Dr. Hawkins is a board-certified radiologist and assistant professor at the Emory University School of Medicine in the Department of Radiology and Imaging Sciences. He also serves as medical director of both the telemedicine program and the vascular anomalies clinic at Children's Healthcare of Atlanta. And today he'll be speaking to us about Project ECHO and the democratization of medical knowledge. Please help me welcome Dr. Hawkins.
All right, well, thank you very much for the invitation to be here today. Let me check and make sure. All right, that's working. Good deal. I got to admit, when I got the invitation from Genetics Group, that was pretty cool. I don't know anything you guys know. And so you are a very valued member of our medical community, and I know how much, particularly in the vascular anomaly space, we've been leaning on you guys a lot lately and have really forged a wonderful relationship. So appreciate the work that you guys do, and thank you for having me today. So why on earth is a pediatric interventional radiologist talking about Project ECHO, and why on earth is a pediatric interventional radiologist the medical director of a telemedicine program, right? That's about as unconventional as it gets. So before we get into the bottom line of what ECHO is, there's not a whole lot of pediatric interventional radiologists, just like there's not a whole lot of you all out there, right? You probably have heard that your services can be hard to come by just because there's only so many people and so many hours in the day. And really that's what is at the core of Project ECHO. And the word democratization, that's very intentional. Of course, that means to make things readily accessible, right? Freely accessible to all people. You'll hear people use the word demonopolize a lot, to demonopolize medical knowledge. But that would suggest that we at academic medical centers are actually trying to keep it all to ourselves and hoard the medical knowledge. And I don't really believe that that's the case. Maybe for some people it is. So it very intentionally chose democratization for the description of what we're trying to do here rather than demonopolization. So let's just talk very basics. Telemedicine aside, let's just talk about medical knowledge and what's happened. More medical knowledge has been created in the last 100 years than in the prior 5,000 years. I don't think this is a surprise to any of us. If you just look at the number of medical journals these days, we barely have enough pages to house the knowledge that's being produced on a daily basis. But then it gets scary. I mean, because we feel good about that top line, but now the second line. Americans receive evidence-based care only 55% of the time when they need it. And that's centered more on chronic conditions. We do a decent job, actually, with acute inpatient medical care. We're pretty good at that. It's when patients need outpatient care for chronic illnesses that we're just very poor. We're barely good half the time. Okay, and then these types of numbers and projections, I don't know who makes them. I can't do this kind of math, but nearly 80,000 Americans die each year from inappropriate care for chronic illnesses. The numbers are fairly staggering, although I don't think anybody's probably that surprised in this audience that we don't do a great job with chronic care, with chronic illness care. So, Project ECHO then started. It came out of New Mexico, and here's the genesis. Why? Okay, so in 2003, there were about 34,000 people in the state of New Mexico with hepatitis C. Okay, but only 1,600 actually received treatment. It's a really, really small number, right? So I don't know. Anybody here from New Mexico? Yeah, I've never met anybody from New Mexico. Okay, there's like 10 people in New Mexico. It's a massive state, and the medical center is in Albuquerque. And not only is it a massive state with broad geographies that you have to span, it's a very poor state. There's a lot of very poor socioeconomic communities in New Mexico. And of course, when you have hepatitis C and you don't treat it, you get liver cancer almost all of the time. So these patients would show up at the University of New Mexico with what was once a treatable illness, hepatitis C. We have really good drugs for that now. Okay, really good drugs for it. A treatable illness, and would show up with advanced stage liver cancer and die. And so Sanjeev Arora, Dr. Arora, who is the founder of Project ECHO, obviously saw this as a problem and wanted to find a way to reach the communities across New Mexico to try and provide care for patients so they didn't all have to travel to New Mexico. Frankly put, treating hepatitis C, particularly the non-complex cases, it's not that hard. Okay, the medication, there's only a couple of medications you can use. There's only a few lab values you have to watch. And then for the really complex ones, you can ship those to Albuquerque as needed. So that was the concept. So as Dr. Arora would say then, that there is a clear need for democratization of medical knowledge because we had to get the knowledge out to the community to take care of patients with a very treatable illness. So this is the Project ECHO model, okay? And I'm going to describe the model, and we'll talk more about the engagement of the community members more than the technology today. And that's that's very intentional. Okay, don't get caught up in the technology of telemedicine. No telemedicine program has been successful because of its amazing blow you out of the water technology. Okay, it's all about the people. But the concept is you have a central hub, so, all right, typically an academic medical center, that then holds weekly clinics. The clinics are attended by other providers all across, in this case, the state of New Mexico, all right? So each week, your clinicians at the outside centers, the spokes, right, this is a classic hub and spoke model, the spokes would submit cases that they wanted to discuss, okay? The hub then would discuss the cases with the providers at the far off places, the spokes, and they try and take care of patients that way, okay? Never is a patient-specific, there's no patient-specific information that's shared, patient-identifiable information shared. This is all done HIPAA compliant. But importantly, the hub is a multidisciplinary team. This isn't just one physician sitting there at the desk, you know, doing a virtual video consult with the providers at an outside facility. These teams often have social workers. They often have psychiatrists or behavioral health experts. There are a few that have geneticists as part of their team, genetic counselors. And so you get this very multidisciplinary approach to these cases. You empower, okay, you empower the physicians or providers at the outside facilities to take care of these patients. And what ends up happening is people keep coming back to the clinic each week. A community begins to build and form, and you actually see these relationships developing between providers that span broad geographies, because it's again, it's more of a community building exercise than a telebroadcasting exercise, okay? As part of each weekly clinic, there's also a 10 to 15 minute didactic session, okay? That's it, just 10 to 15 minutes, nothing more than that. What we don't want echo clinics to become is like virtual grand rounds, right? Where it's just, you know, some guy or gal sitting there just talking to the providers. That's not what people want to join to be a part of, right? We don't need another virtual grand rounds. Goodness sakes, we know that there's enough of those already available. But because they do 10 to 15 minutes of didactic, you also can get CME credit for the providers at outside facilities, and so it's funny how much that draws people in. Okay, all right. So you do get CME credit as part of joining these clinics. Most of the clinics, there's a time frame that's sort of set with the curriculum, right? So somewhere between 10 and 15 weeks, you have a set curriculum of topics you want to talk about, okay? And the spoke sites sign a contract. Actually, it's an agreement, but they're going to join each week for that set of time, and so that they're coming back each week and actually being a part of the community, okay? So again, you're noticing the difference between Project Echo and virtual grand rounds as I describe this, okay? All right. Here we go. All right. Okay, good. So what ended up happening after they developed Project Echo out in New Mexico and they started treating hepatitis C, they started noticing some unbelievable results, okay? And this was really the paper that kicked it all off. There have been a lot of sort of cutesy telemedicine projects that have been done out there. Very few are actually truly impactful. We usually sort of inflate the impact of them. Okay, this was no joke. So this got published in Hepatology. Hepatology, if you are ever involved in the world of GI, hepatology, and nutrition, that's their landmark journal, right? And so they started noticing improved survival rates, improved compliance, improved satisfaction from providers that were participating in the echo clinics, so really profound results. And that's really what got this kicked off to the point where Project Echo in New Mexico is funded with over $1 million a year from the state legislature. They now have their own building on the University of New Mexico's campus, and it's just expanded into something very impressive. So there's a lot of literature on Project Echo, and I'm showing you this more just so you understand all of the different specialties that have embraced this movement, okay? You can see here a group has published work on autism. Behavioral health has been hugely benefited by Project Echo, right? I mean, we know that we don't have enough behavioral health specialists in the United States, but have been able to bridge some of those gaps with Project Echo. Diabetes, right? Oh my goodness gracious. good Lord, I could use 5 or 6 more pediatric endocrinologists just down the street at Children's, let alone across the United States. So diabetes, huge potential there. A lot of work in the pain space, a lot of pain management, very difficult patients to deal with. And if you haven't had training in pain, you can see why being able to tap into a central hub to get guidance from peers is very, very helpful. Palliative care, same thing. We know we're not training enough palliative care specialists in the United States. Sickle cell, also a growing population, but takes a lot of subspecialty. It takes a lot of specialty knowledge to take care of sickle cell, especially in the modern era. Sickle cell patients live all over, so we're finding ways to connect with these patients. Let's go to that next slide if we can. Is there just too much echo? Okay. Okay. Let's go ahead and go to the next slide then. We could? All right, great. And then the last couple of papers, and I'll stop going through literature here. You can see substance abuse also has been published about. In fact, now there's enough peer-reviewed literature that they had enough to actually do a systematic review, right? That's when you know you've made it as a topic. It's when someone can do a meta-analysis or a systematic review, okay? So a lot of people have joined in the ECHO movement. It has now, let's see the overall span. So they've got over 30 clinics now at New Mexico alone. And again, these are weekly clinics. And we're going to talk about what some of the keys to a successful clinic are and some of the barriers of implementation. Nationally now, over 30 states. We were the 4th pediatric center in the United States to start our ECHO clinics here at Children's. We were excited about that. They're treating now over 65 different medical conditions. They've got it in multiple countries now. And admittedly, hepatitis C has been the sort of showcase disease, if you will, that's been implemented really across the world. Again, you're talking about one organ, one virus, 2 medications. So it lends itself to an ECHO clinic, certainly not as complex as some of the diseases and disorders that you all are involved in treating. But they've actually set a goal. They want to touch 1 billion lives by 2025, and they're actually on their way. They are well on their way with Project ECHO. In fact, this has gotten so much attention that we have an ECHO Act, federal legislation, okay, that passed the House and the Senate this last December, basically ordering or demanding that the Secretary of Health and Human Services study this model and find ways to budget for implementation of this model across the United States for all populations, okay? So to review the first part, Project ECHO, extension for community healthcare outcomes, a collaborative model of medical education, again, not virtual grand rounds, collaborative model for medical education where you discuss patient cases. And then you get follow-up on patient cases, right? Those same people come back to clinics, you can do follow-up and see how patients are doing. An innovative model for clinical care enhancement with a focus on case-based learning. So let's talk about what telemedicine is, because telemedicine is not Project ECHO. I alluded to this earlier. Telemedicine is pretty simple, right? I sit down at a computer screen. Again, I'm one of the few peds IR docs in the state, and I have patients all over in Valdosta and Savannah and everywhere else. I sit down at a computer on a screen, and we use whatever software it is you want to call it. Patient is at a remote site, usually with a nurse or some other medical assistant, and I talk with patients, and we have fancy Bluetooth technology now that lets me listen to their heart and their lungs and all that stuff, okay? But that's really no different than just sitting in an office and having a meeting with a patient, right? So what ECHO clinics do, you work with primary care teams, for the most part primary care teams, does not have to be primary care teams, but you're sitting there working with primary care teams, answering their questions, helping them work through cases, teaching them how to take care of some of these diseases that we just don't have the medical providers to take care of, and then they go out and they reach the patients. Right, so very, very important to understand this. We've had more than one ECHO that we tried to kick off at Children's, where the providers were not clear about this and they wanted to make it a virtual grand rounds. So I know it seems really simple when I put it up here on the screen, but when you guys start to sit down and make your curriculum, keep it in mind, okay? Your goal is to teach other people how to take care of these patients. One of the things that they talk about for a successful echo clinic, if you want to pick a topic, right, because where do you start? Right? You can start anywhere. We looked at places where there's inappropriate referrals or long waiting lists, right? So like our pediatric neurologists, for example, and we got a neurology echo that's going to start here soon. They get a ton of referrals for headache, right? Very, 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 very few children with headache need to see a pediatric neurologist, okay? So I don't know how that would work in your space, but if there are things that you guys are continually getting referrals for that you're like, this is crazy, you don't need a genetic counselor for this, perhaps that's a place that you could target, although I certainly don't know what the bounds of the grant are, or what the requirements are for the funding of this. So why Project Echo at Children's? There's just not a lot of pediatric subspecialists, and it turns out we're the only children's hospital in the state of Georgia, right? There are some pediatric wards in Macon and Augusta, but as far as the number of subspecialists, we have a problem in this state accessing kids, particularly in South and Southeast Georgia. So it was a big deal for us to get this off the ground. There are multiple studies, as you can imagine. Project Echo decreases travel expenses. It decreases the days that kids have to miss school because they don't have to travel to Atlanta. Decreased work days missed for parents, right? That's another aspect of pediatrics that we think about the school days missed, but we don't always think about, the work days missed by parents. And again, by choosing wisely what diseases or echoes we wanted to implement, we think we've been able to start making an impact across the state. It increases the ability for local providers to care for complex patients. It gives the providers access to subspecialists. So just those conversations about patients gives them great confidence on being able to go back and take care of some of these diseases they used to refer. It does promote professional interaction with colleagues. I don't think it doesn't hit us as much in Atlanta when we're at a big academic center like Emory, but some of these docs out in the communities, way out in the communities, they don't have that same collegial, professional, peer-to-peer interaction every day, I think, that we take for granted. So again, one of the surprise, maybe not a surprise, but one of the findings from the literature on Project Echo is the increased satisfaction that the community providers have really enjoyed from being a part of these echo clinics. And then, of course, the no-cost CME credits, right? People are suckers for CME credits. I just still don't understand why, but they are. All right. Briefly, we talked a little bit about the format. I'll reinforce it here. 15 minutes didactic, tops, right? Tops. Don't invite that person that's going to talk for 30 minutes when you ask them to talk for 15, right? Just don't do it. The value from echo clinics, because I've observed many of them myself in New Mexico as well as here. The best echo clinics are where you just go through tons of cases, right? You can't always go through Dr. Aurora for hepatitis C, right? That's become a machine now. So when you go out there and you watch his echo clinic, they'll go through like 15 cases. Again, one organ, one virus, 2 medications. It doesn't take very long, right? Some of the behavioral health or psychiatric echo clinics, 1 or 2 cases. Okay, so there's no way you have to do it, but the cases are where the value is, not the lecture. Okay. I'm going to talk about technology. You have to talk about technology when it comes to telemedicine, but I always reinforce with our team at Children's, telemedicine is not about the technology. It's about people and change management. But there is some technology we have to know about. So again, this is a hub and spoke model. Academic medical centers, the hub. As many communities as you want out there can be the spokes. The optimal number of spokes depends on what you're talking about. The folks out in New Mexico would tell you 12 to 14. You don't want to get more than 12 to 14 spokes for an echo clinic. I've seen clinics, though, where there's 25 or 30, and they seem to work well. Okay, so I do think a lot of it just depends on the topic at hand. But if you're out at a spoke, so you're out at some physician's office in Valdosta, this is what you see. And I think there's a couple important things here. Number one, video. Okay? You got to see the other people's faces. It's very difficult to build a community when you don't know what people look like. It sounds odd, but it's true, okay? It's like trying to build a community with, pen pals and writing letters to people. It's very difficult to do. So you need video. The software that comes with Project Echo. So if you sign up with Echo and you sign their agreements that you're going to put on and participate in Project Echo and host a clinic, it's a software called Zoom. Anybody use Zoom? Yeah, it works really good. It's one of the easier, it's like any of the other GoToMeeting or anything like that, except for Zoom has a nice feature. If you use GoToMeeting, for example, the speed of the internet and the video drops to the lowest common denominator. So whoever has the lowest internet speed is what everyone has to deal with, right? That's terrible. Zoom does not deal with that. So your speed and how well it works is based on your connection, not the other people that you're part of the meeting with, okay? That comes free when you agree to do an Echo clinic. So you sign this contract with Echo. Echo then gives you the license to use Zoom, okay? But this is what you see as a spoke. And again, importantly, you don't just see the hub, right? You see all of the other people that are participating in the Echo clinic. The community, building the community is the hardest part of Echo. It's also the single biggest factor of success. Okay. Now the hub, this is what it looks like. Oh, by the way, I probably should point out is this the laser? I don't want to turn it off. That's Dr. Aurora. Okay, so in case you're wondering who that dude is sitting in the middle of the table, he's the guy that founded and started this whole thing. So now at the hub, this is what it looks like. Again, you see all of the different spoke sites. You also see the multidisciplinary team, right? So this isn't just one, again, not just one physician. There is usually a clinic nurse for each Echo clinic that takes in the cases, triages the cases, and preps them for presentation, okay? But then you also have, well, whoever the team is, sometimes you'll have a social worker, again, behavioral health specialists, genetic counselors are a big part of them. There might be other subspecialists, right? So if you're doing headache, you may want a neurologist, you may also want a neurosurgeon or something, for example. That's just an example, okay? And then you just work through the cases. The didactic, usually it starts with the didactic from the hub, and then the clinic nurse, he or she has selected the cases that they're going to talk about, and the spokes present them just like when you were in training, right? 45-year-old female, da-da-da-da, lab values this, and then they discuss, okay? So how we've set it up at Children's, I think this is another thing that's important to talk about. We have centralized all of our echoes through the telemedicine team, okay? This gets more into organizational logistics. We found that that's worked well, and the reason we've done that is because otherwise anybody everywhere could just start an echo, and it's difficult to make sure that we're doing it the best that we can if everybody could do it a little bit differently. Okay, so at least this way it all drives through our telemedicine team, and I'll talk about who our team is. We have one project manager who is dedicated just solely to Project Echo. So Charlotte Guest is her name. I've got her email address at the end of this because she'll be an excellent resource for you. She knows Echo better than anybody. We have other members of our telemedicine team, but her job is to run Project Echo. And it's a big job, right? Because every Echo clinic that you start, you have to recruit. First, you have to recruit your spokes. It sounds like you guys already have a great network, so it might not be an issue. But you have to recruit your spokes. You have to make sure that they're technologically set up. You don't need much these days. I mean, you pretty much just need a tablet and the Zoom software, but you have to make sure that they're all set up. You have to get the clinic nurse. You have to find the physician team leader that's going to run the Echo clinic, and then always be present for all the Echo clinics to make sure logistically everything works. So it's a big job. We have one person totally dedicated to it, and it's worked well for us. These are the Echo clinics that we're running currently here at Children's, okay? We just launched behavioral health. We're pretty psyched about that. That's a very multidisciplinary team reaching primary care pediatrics offices across the state of Georgia. Had a very enthusiastic first clinic here just 2 weeks ago. Follow-up was just as good. So I think that's going to be a very, very successful Echo. And again, it addresses a real need. To get into a behavioral health specialist at Children's takes forever. It takes forever. So very excited about that. And then we've been very successful at the Blank Center, the Child Protective Services. Okay, that we have a very well-developed group here, a huge need for care in that space. And so we have a child abuse and neglect Echo. That is a monthly Echo where again, you have pediatricians, primary care, you have police, detectives, you have all as part of the Echo Clinic every month. Very dynamic discussions there. There's only Child Abuse Pediatrics Fellowship. So this is a really creative one. There's only, I think, 8 or 9 places in the country where you can do a fellowship in child abuse in pediatrics. It's a really, really small number. And so what they did was they decided to develop a curriculum so that now if you do a child abuse fellowship, everybody's getting trained the same way, right? Because they participate in these Echo clinics. Now, it took some creativity in how you're going to make this case-based, right? Because what I just told you sounds a little bit like virtual grand rounds, right? But they've done a really nice job. Steve Messner really has led the charge at the Blank Center, done a great job with that fellowship. And then, you know, something I didn't even know was an issue, but the commercial sexual exploitation of children, because we live in Atlanta. Huge, huge problem here in Georgia, and not a lot of ways to make sure these kids are getting the care that they need and the protection that they need. So the Project Echo in New Mexico has been very excited about all of these Echoes, because for all 4 of those, they are the first of their kind in pediatrics anywhere in the world. They've been very successful. Then the 2 that we're getting ready to launch, very excited about these. Cancer survivorship, right? So for your kids that, you know, they've had cancer, they've had tons of chemotherapy, now they're 21, they've got fertility issues and hormonal issues and all these other things because they've been getting slammed with chemo for years and years. Lillian Meacham's going to get that off the ground. She's the perfect person for it. And then neurology. We're finally going to get our neurology Echo off the ground, which I think we have like 6,000 kids on the waiting list. That number is not even like a real number, okay? But that's what it is right now at Children's. Here's some of the impact that we've had. We've got 80 individuals in 20 different practices within the Children's Care Network signed up for the Behavioral Health Echo. We've got 34 individuals, 18 different organizations in 14 cities in Georgia in the Child Abuse and Neglect Echo. In the Child Abuse Pediatrics Fellowship, right, 144 individuals, 40 organizations, 22 states. And then the CSEC, 80 individuals, 21 different organizations throughout Georgia. And so it's pretty impressive what can be done. And we're a small shop, okay, compared to some of the other places that have adopted Project Echo. We're very small. You look at places like the University of Washington, for example. University of Washington is, I did my training out there for IR. They are the academic medical center for Alaska, Idaho, Montana, northern Wyoming, the entire state of Washington. So they have this huge geography. And so their Echo clinics, they have people from all those places. So big, broad geographies. They've been ragingly successful. But for us in our little pediatric shop, we're doing some good stuff. These are all YouTube videos. We are not going to sit here today and watch all of these YouTube videos. But some of them are, the TEDx, the TED Talk's it's actually fantastic. That's the best 8 to 9 minute summary from Dr. Aurora about what Project Echo is. I want to talk just for a second, and these are the email addresses of people you guys probably should be in touch with, particularly Charlotte down here on the right. A couple of keys that I see to implementing a successful Echo clinic. Number 1 is who you pick to run it, okay? So usually it's a physician. I don't know in the genetic space if that would be the case or not. Obviously it does not need to be a physician. The best Echo clinics tend to be run by your very enthusiastic people who win teaching awards. Think about those people, okay? It's when you get the old miserly doctors that want to, again, run it like a grand rounds and just tell everyone how smart they are. Those don't work. They get launched. They always get launched, but they don't work. So that's number 1. You got to find somebody. Think about who wins your teaching awards. That's who you want to run your Echo clinic. Number 2, I have never seen a successful Echo clinic anywhere in the world work unless the person leading that clinic gets at least 0.1 of their time funded somehow. Sounds like you have a funding mechanism. You're already off to a great start. Okay, when you ask physicians or providers to run a clinic on their volunteer time, it always starts off great. Again, they always get launched, but eventually that wears out. So those are the 2 biggest keys. And then also making sure you find that right clinic manager, the nurse manager to help run that clinic. You know, that's the person that's going to be connecting with the spokes. That's going to kind of be the glue that keeps it together as cases are coming in and you're triaging through cases. Okay, so don't underestimate, especially those first two things. Okay, and with that though, I will close, and I'm happy to take any questions you guys might have about ECHO. Thank you guys.
You know, genetics, we deal with patients throughout life cycle, pediatrics and adults. What kind of a relationship at Emory we have with the adult component? And the second part of my question is, how many echo centers totally there are? Is there only a couple in Georgia, or is there a listing of national, or is there a organization which is keeping up with all the echo centers and the kind of deliverables they're giving?
So when you decide you want to run an echo clinic, so you're going to do it, right? We're going to do a genetics echo, whatever topic in genetics you want to do. The first thing you do is you actually reach out to the echo team in New Mexico. Okay, they'll do a couple things for you. Number one, they have what they call an immersion training. I absolutely recommend that whoever you have lead your clinic, if it's going to be you, go to immersion training. That's where you're going to learn. That's where they have a number of tools for how to run a successful echo clinic. They have a whole database for how to track outcomes as part of each echo clinic. You decide what the outcomes are, but then they have a central repository. It's similar to, like, I don't know if you're familiar with Epic Clarity. Clarity is the background database on Epic, right? So you can get into Clarity and actually start digging around on the data that you have and come up with some stuff. They have something similar. It's called iEcho. So you want to work through them. They'll give you the agreements that they want you to sign as part of their free license with Zoom. They'll give you a format of the agreement that you want to have your spokes sign when you start. So work through Echo. That's who keeps track of all the echoes going on then across the state. I don't know that number right now. From a pediatric standpoint, the only places doing echo that I know of are, there's one in Chicago, one in Missouri, one in Washington, and then us. And of course, those are growing. And they cover a broad range of topics. But you definitely, before you launch this, go out to New Mexico and get plugged in with that group. As far as at Emory, Greg Esper runs telemedicine there, so he and I work fairly closely together, and our teams work closely together. They've not launched any echoes yet, but he loves the program and would love to get it off the ground. Clearly, this would be genetics is something that you need both peds and adults for, so we just have to work through that. I don't see any barriers. I'm just sure that between those two organizations, there will be much discussion to make that happen. Excellent. Perfect. So you're already connected with the right people. Yeah. So I'd say I recognize you back there. Yep. And so it wouldn't really change the format at all. Where it would get a little interesting is that point. Well, I say point 1. I would love it to be point 2. I know that's a stretch for organizations, but whoever that person is and where that funding comes from would be the only thing. Otherwise, we have space at both facilities to make it happen, and certainly the technology to do it.